Welcome to our second and last video on fat-soluble vitamins. Let's begin. Here are the topics we're going to discuss in this lecture. Let's start with vitamin E. We will cover general information, vitamin E deficiency, vitamin E toxicity, and therapeutic uses of vitamin E. Let's start with general information. Vitamin E is also known as tocopherol. Its main sources are vegetable oils, nuts, and green leafy vegetables. The storage site is the adipose tissue. Vitamin E has two important functions. First, it plays an antioxidant role, preventing free radical damage, especially in erythrocytes. Second, it can inhibit cell proliferation and platelet aggregation. Let's continue with vitamin E deficiency and discuss its causes. The main cause, as in most fat-soluble vitamins, is poor intestinal absorption that occurs in settings of pancreatic insufficiency, small intestine resection, cystic fibrosis, and a beta-lipoproteinemia. Let's recall that A beta-lipoproteinemia is an autosomal recessive condition which presents with severe fat malabsorption, retinitis pigmentosa, spinocerebellar degeneration, and acanthocytosis. The clinical presentation of vitamin E deficiency is marked by hemolytic anemia and neurological dysfunction. Hemolytic anemia results from increased fragility of erythrocytes and manifests as pallor, fatigue, dark urine, and jaundice. The neurological dysfunction includes ataxia and decreased proprioception and vibratory sensation. This is due to demyelination of the posterior column and the spinocerebellar tracts in the spinal cord. Coming to workup, the formation of acanthocytes is characteristic, which are erythrocytes with cytoplasmic projection seen on peripheral blood smear. Serum alpha tocopherol levels can be measured. As for the treatment, large doses of oral vitamin E should be prescribed. This is a peripheral smear showing numerous acanthocytes. We can notice these irregular red blood cells with thorny projections. A 20-year-old man comes to the physician due to worsening fatigue and dyspnea on exertion that started 1 year ago. He no longer jogs in the morning because he gets easily tired. His past medical history is significant for celiac disease treated with gluten-free diet. However, he admits being intermittently non-compliant with his diet. The physical exam reveals a positive Romberg test along with impaired vibration sensation in the lower extremities. He has a wide stance to prevent swinging from side to side. His hemoglobin is 8, with MCV of 90. What is the best next step in the diagnosis of this patient? This patient presents with worsening fatigue and dyspnea on exertion. Additionally, his hemoglobin is low, but his MCV is normal. Therefore, his fatigue is most likely due to normal cytic anemia. He also has a positive Romberg test along with impaired vibration sensation in the lower extremities, indicating possible damage to dorsal columns of the spinal cord. He has a wide stance to prevent swinging from side to side. This indicates ataxia, possibly due to spinocerebellar tract damage. His past medical history is significant for celiac disease, and he is sometimes non-compliant with the gluten-free diet. All of these findings suggest vitamin E deficiency. The best next step in the diagnosis of vitamin E deficiency is to measure serum alpha tocopherol levels. Let's move on to vitamin E toxicity. It is very rare, and its main cause is oversupplementation. The clinical presentation includes abdominal cramps, diarrhea, or nausea. The toxicity increases bleeding risk in patients taking vitamin K antagonists such as warfarin, because high supplementation doses alter metabolism of vitamin K. In other words, it enhances the anticoagulant effects of warfarin. Finally, in neonates, it has a risk of necrotizing enterocolitis. Necrotizing enterocolitis is the most common gastrointestinal emergency in neonates. It usually manifests within the first few days of life with feeding intolerance, abdominal distension, and bloody stools. X-ray of the abdomen may show pneumatosis intestinalis, which is intramural air bubbles produced by bacteria. The diagnosis of vitamin E toxicity is primarily clinical. However, it can be detected by obtaining serum levels of alpha tocopherol. Its treatment is based on discontinuing the exogenous supplementation of the vitamin. Let's end this section with the therapeutic uses of vitamin E. Vitamin E has been shown to have some benefit in non-alcoholic fatty liver disease with an improvement in aminotransferases and histological abnormalities. This improvement is due to the antioxidant effects of vitamin E. In addition, in patients who have age-related macular degeneration, it could delay the progression of the disease. Let's conclude our lecture with our last section, vitamin K. We will cover general information, vitamin K deficiency, vitamin K toxicity, and the therapeutic uses of vitamin K. Let's start with general information. Vitamin K is also known as phytomenadione, phytonadione, phyloquinone, and menaquinone. Its main sources are leafy vegetables, eggs, dairy, and also synthesized by the intestinal flora. It's stored mainly in the liver. The function of vitamin K is related to coagulation, specifically the activation of factors 2, 7, 9, 10, protein C and S. Let's continue with vitamin K deficiency. Risk factors that can lead to deficiency are antibiotic therapy, warfarin use, liver failure, malabsorption, and the neonatal period. The latter is due to the fact that vitamin K does not cross the placenta and it is not found in breast milk. Also, the intestine of neonates is sterile, so there's no bacteria to synthesize it. The main clinical presentation of vitamin K deficiency is a bleeding disorder because factors 2, 7, 9, 10 cannot mature. This can include melena, mucosal bleeding, intramuscular bleeding, and hemorrhagic disease of the newborn. The hemorrhagic disease of the newborn classically presents between the 2nd and 7th day of life with bleeding from mucosal surfaces, the gastrointestinal tract and umbilicus, and intracranial hemorrhage. It is a preventable condition by the administration of intramuscular vitamin K. Let's move forward discussing the diagnosis of vitamin K. There is increased prothrombin time and partial thromboplastin time. However, bleeding time is normal because there is no platelet deficiency or dysfunction, and the primary hemostasis is intact. Treatment is based on vitamin replacement as well as preventing deficiency in neonates. This is performed by administering intramuscular vitamin K as a postnatal prophylaxis. A 3-day-old boy is brought to the physician due to lethargy and vomiting. He was born at home at 40 weeks of gestation via vaginal delivery. His mother had no complications during pregnancy. His vital signs include a blood pressure of 50/40, heart rate of 180, and a respiratory rate of 70. The neonate experiences alternating tonic and clonic muscle contractions for 2 minutes. The head ultrasound reveals bleeding into the ventricles. The physician explains to the parents that bleeding is due to deficiency of a specific nutrient. How does the deficient nutrient contribute to normal functioning of coagulation system? This 3-day-old boy has lethargy and vomiting. The neonate experiences alternating tonic and clonic muscle contractions for 2 minutes. This description is consistent with a tonic-clonic seizure. The head ultrasound reveals bleeding into the ventricles. The physician explains to the parents that bleeding is due to deficiency of a specific nutrient, which is vitamin K. This neonate has a vitamin K deficiency because he was born at home, and he likely did not receive postnatal vitamin K intramuscular injection. Vitamin K is a cofactor of the hepatic enzyme gamma-glutamyl carboxylase, which activates factors 2, 7, 9, and 10, protein C, and protein S. Normal concentrations of these procoagulant and anticoagulant factors are important to prevent excessive bleeding. Let's continue with vitamin K toxicity. Its toxicity is extremely rare. However, it can happen if there is over-supplementation. It manifests with signs and symptoms of hemolytic anemia like fatigue, pallor, jaundice, and kernicterus in infants. Kernicterus is the chronic and irreversible form of bilirubin-induced neurologic dysfunction with permanent sequelae. The diagnosis of vitamin K toxicity can be made by determining the patient's history of vitamin K supplementation along with findings of hemolytic anemia. Hemolytic anemia can be determined by increased LDH, decreased haptoglobin, and indirect hyperbilirubinemia. Treatment is based on stopping vitamin supplementation. Now let's conclude our section with the therapeutic uses of vitamin K. As we discussed, it works as an anti-hemorrhagic factor in neonates, and it is also useful in blocking the effects of oral anticoagulants such as warfarin. However, it takes time and should not be used for acute warfarin toxicity. Let's end our lecture with a board-style question. A 6-year-old girl was brought to the physician by her parents due to severe fatigue for 6 months. She was premature and underwent ileal and distal jejunal resection due to necrotizing enterocolitis. She has had fatty stools since then. Her vital signs are unremarkable. The patient tends to fall when she tries to stand with her eyes closed and arms stretched out in front. She also swings from side to side while walking. Laboratory findings are significant for hemoglobin of 9 with MCV of 87 and acanthocytes on the peripheral blood smear. Supplementation of which of the following nutrients is most likely to resolve this patient's current symptoms? A. Vitamin B12, B. Vitamin B9, C. Vitamin E, or D. Vitamin K. This young girl has had fatty stools since her ileal and distal jejunal resection due to prematurity-related necrotizing enterocolitis. This finding indicates malabsorption due to short gut syndrome. Currently, she presents with severe fatigue for the past 6 months. The patient tends to fall when she tries to stand with her eyes closed and arms stretched out in front. This clue represents the positive Romberg test. She also swings from side to side while walking, which indicates ataxia. A positive Romberg test can be caused by dorsal column dysfunction, while ataxia can be caused by spinocerebellar tract dysfunction. Laboratory findings are significant for hemoglobin of 9 with MCV of 87 and acanthocytes on the peripheral blood smear. Normocytic anemia and acanthocytes, along with neurological dysfunction, is characteristic of vitamin E deficiency. This patient is likely deficient in vitamin E due to malabsorption. Therefore, vitamin E supplementation is the most likely to resolve her current symptoms. The correct answer is option C. Here's a slide reminding us of the clinical presentation of vitamin E deficiency. Let's discuss why other options are incorrect. Option A is incorrect because although vitamin B12 deficiency leads to neurological dysfunction, it causes macrocytic megaloblastic anemia without acanthocytes. Option B is incorrect because vitamin B9 deficiency causes macrocytic megaloblastic anemia without acanthocytes. Additionally, it does not lead to neurological signs and symptoms. Finally, option D is incorrect because vitamin K deficiency leads to increased bleeding tendency rather than neurologic dysfunction and normal cytic anemia. And that concludes our lecture on vitamins E and K.